Welcome everyone to this nutrition training program promotional webinar. This training program is a great and very new program for the European Society of Intensive Care Medicine. And I will give you a very short introduction of this program. Today, this is only a promotional webinar. Well, it's the start, and then it's followed by a self-study period until June 19th. We have a live event with a course and tutorial sessions on June 30th and the 40th. And you have the opportunity to take part on a fellowship, meaning that you will be allowed to participate in another ICU 1 week in a different country and experience seminars, teaching from experts in the fields. To become part of the fellowship, however, we have only limited places. There will be a selection which will be discussed later. We also will have research awards at our LIVES Congress in October. This program, as I told you, is new and is supported by Fresenius Kabi in the form of an unrestricted educational grant. So the program has not been influenced by the sponsor in any way. I would like to introduce you now with the task force of this program. On the left, you see Danielle BEAR, a dietitian and PhD. She's currently working as principal critical care dietitian and acting clinical and operational lead for dietetics at Guy's and St. Thomas NHS Foundation Trust in London, UK. She's also a member of the Metabolism, Endocrinology and Nutrition section of the European Society of Intensive Care Medicine. Carole BOULANGER, an advanced critical care practitioner and round nurse, currently works at the Royal Devon and Exeter NHS Foundation Trust. She's also a member and was the representative of the Nurses and Allied Healthcare Professionals Committee of the European Society of Intensive Care Medicine. Michael CASAER, medical doctor and PhD, currently works at the Intensive Care Medicine Department, Burn Center and Ethical Committee at University Hospital Leuven, and Laboratory of Intensive Care Medicine at CMM and Academic Center for Nursing and Midwifery at Catholic University Leuven. He is also the current chair of the Metabolism, Endocrinology and Nutrition section at the European Society of Intensive Care Medicine. My name is Stefan, and I currently work at the Department of Anesthesiology and Operative Intensive Care Medicine at the Charité University Hospital in Berlin. I'm an anesthesiologist and the Deputy Clinical Director here, but currently the chair of the next committee of the European Society of Intensive Care Medicine. So this program is for members of the European Society of Intensive Care Medicine. It is for intensive care doctors, nurses, and allied healthcare professionals. It's our first really multi-professional, interprofessional program. And for people of the society who wish to improve the knowledge and skills in the field. We will have a lot of content, and you can see we will cover importance of feeding, understanding nutrition and research, nutritional assessment, nutritional targets, enteral nutrition, parenteral nutrition, monitoring and complications, protocols, and also quality improvement and knowledge transfer to the bedside. And lastly, our timetable approximately for today, because the most important thing for us today is the interaction with you. So please ask your questions, and we will try to discuss in the roundtables, in the question and answers, everything what you are interested in. I really invite you to take this opportunity and ask the questions you always had to our panel of experts. So I want to conclude with the timetable. I think I will not read it for you. You already saw it now here. And now I want to hand over to Michael. Thank you very much.
Thanks very much, Stefan, for this great introduction of this great novel program. And I'm very happy and honored to start off the first part of this webinar with Danielle BEAR. And we're going to talk about two very important things. One, I hope you're all convinced, but still we'll try to convince you even more that nutrition is important in the intensive care unit. And two, even more important, it is multi-professional, as everything that we do, but particularly for nutrition, this is certainly the case. So in the next 20 minutes, Danny and I'm going to one by one discuss a few titles. The first one, nutrition is everywhere. The second one, every ICU needs a nutrition protocol. Then promoting anabolism and recovery, preventing and detection of harm by nutrition, and finally, nutrition therapy doesn't stop at your ICU doors. So just some ideas. Of course, we're not going to give all course today. It's only to introduce you with these ideas that will be discussed in the classes in a few weeks or months. So yeah, nutrition is everywhere. You might think this is very obvious. Why do you mention this? But in fact, I've been lucky to come at congresses with nutrition and ICU experts. And many ICU colleagues say, oh yeah, nice nutrition, but it's not really my thing. I'm not really into nutrition. But in fact, if you treat human beings as a nurse, allied health personnel, or MD, you are also doing nutrition one way or another. Maybe you're feeding, you're fasting, but you do something. Some of our patients do feed themselves. And this is also important, particularly when they get better and when they are the most in the anabolic phase. And this should also be taken into account, of course. The nutrition therapy doesn't stop when patients start eating themselves. As you know, many patients are unable to feed, and our protocol is focused on keeping things simple. So the first thing that we'll do if patients don't have the energy to consume normal oral feeding is give some oral supplements. If this is not sufficient, we switch to enteral nutrition, and here, and this will be discussed, of course, in extenso in the course, we have to decide between gastric feeding or intestinal feeding by the nose or maybe by transcutaneous access. And these are all decisions that have their own impact, and that should be taken with all consideration of the clinical situation. And then in some patients, the only route is the intravenous route. And there's quite some discussion, sometimes overheated discussion, in whom it should be used. Well, if there is a gut that is not functioning due to a hole somewhere between the stomach and rectum, then of course you need parenteral nutrition. We mostly give it by a central line if it needs to be full parenteral nutrition. And then some people like to give it in many other situations, which has been studied over the last years in several studies. But even if you don't have the intention to feed, even the first hours, or for some people days, when they say, oh, nutrition is not my concern today, we should realize, and I hope we do all realize, that our drugs and our infusion fluids and our dialysis fluids contain dextrose, lactate, acetate. Antibiotics are diluted often in quite some amount of dextrose. We have the citrate, which is also a fuel for the mitochondria in the packet cells and dialysate. And of course, I hope we all realize when we give propofol in adequate doses for deep sedation, that we give together with it an important dose of soybean oil. And this, while propofol itself has a negative impact on mitochondrial oxidation. On the left-hand side of this last slide of this paragraph, you see a lot of numbers which are not readable, which is not a problem, because the only thing that's important here is to realize, as discussed by Katz and colleagues, when you try to give a person a ketogenic diet, so you want to fast him and make him produce ketones, among others, in situations of refractory epilepsy, then you realize how easily these ketones go down, because due to all kinds of interventions done with your patient, drugs and other therapies, that in fact every time give some nutrition that you never realized you were giving. So it is everywhere. And then I'll hand the slides to Danny.
Thank you very much, Michael. You mentioned something really key, I think, at the beginning of your slides, and that is that most of us, I think, understand that nutrition is a really, really important part of the care that we provide to our ICU patients. And I think these two pictures here, thanks for providing them to us today, Michael, really highlight how important nutrition is for our patients, because I think we can see that there's absolutely no way that these patients are going to be able to recover without adequate nutrition support. And one of the ways that this is managed in a lot of intensive care units is via nutrition protocols. Now, these look very different for every single intensive care unit, depending on the types of patients that you have on your ICU, whether that's trauma or burns, or you're a mixed medical surgical ICU. And it will also depend on how much nutrition support you have from clinicians. So whether or not you have a dietitian, or whether or not most of your nutrition is managed by your nursing staff and your medical team. And that will really determine the type of nutrition protocol that you have. Michael, if you wouldn't mind going to the next slide, please. Thank you. I think most centres will have an enteral feeding protocol at the very minimum. And again, I think in the discussion later, it'll be really interesting for us to hear whether or not you do have a feeding protocol or you don't, and what that looks like. And we'll talk about this in more detail on the 2-day course. But essentially, a feeding protocol should advocate for early enteral nutrition, but it does need to consider safety and feasibility. So safety of the nasogastric tube placement, and also have an element regarding management of gastric residual volumes. And my opinion as a dietitian is that these feeding protocols really are only suitable for around 48 to 72 hours. And most patients do require some sort of adjustment to these feeding protocols to suit their individual needs, because it's quite impossible to have all of that information in one protocol and to consider all of those individual differences. And next slide, please, Michael. So I'm just going to show you here a just example of our enteral feeding protocol that we have on our ICU at Guy's and St Thomas's. And as I mentioned, everyone's looks very, very different. But if you can click the slides twice, please, Michael. Thank you. And once more. Thank you. The first element of this feeding protocol talks about the safety and feasibility of starting enteral feed. And then the second part of this protocol talks about how we would manage gastric residual volumes. And again, that will be very different across each intensive care unit. Next slide, please. And then we provide information on 2 different enteral feeds. So one of ours is what we call a standard feed, which we tend to use a high protein feed. Again, that might be very different for intensive care units. And we also have an option of a volume restricted feed. Now, this feeding protocol is nursing led. So essentially what happens is the patient comes into the ICU, the physician gives the okay for the patient to start feed, and the nurse goes ahead and starts that feed. And that is one of the ways that we are able to make sure that our patients receive early enteral nutrition. If you can go to the next slide, please, Michael. And the next one. Thank you. So that's just one example of an enteral feeding protocol that we provide. And I think it's important that all ICUs have at least that type of protocol. But other intensive care units might have protocols for parenteral nutrition, to manage refeeding syndrome. And again, as I mentioned earlier, these will be dependent on whether or not you have a dietitian or the capability and capacity to be able to perform individualized nutrition assessments for your patient, and will of course be determined by the type of patient that you have in the ICU. And hopefully we'll have some good discussion on these points a little bit later.
Thanks, Danny. That was great. And I hope that not only the course, but also the fellowship will allow us to have much more interaction and discover how every one of us tries to organize this, aiming to promote anabolism and recovery. This is something that improved over the last, I think, 15 or 20 years. When I started, lots of the attention was focused on survival, particularly 28-day survival, and also reducing the caloric debt and this kind of stuff. While the last, I think, 10, 15 years, more and more, our focus shifted towards long-term functional outcome, long-term survival, but also where are people, are they independent, and can they make the transition? It's the same patient as you saw on the slide, a few slides earlier, from a severe trauma patient to someone walking out and having a good life. That's what we want. It's very ambitious. It's very difficult. In the early phase, we see, and not only we in Leuven showed this in the study of early parenteral nutrition, where you had wasting of the muscles between day 1 and day 7, independent of the doses that we gave of energy and protein and insulin, but also sodium potassium, and others showed exactly the same wasting and how difficult it is to stop it. And one of the problems is that at some point, the additional nitrogen given is largely wasted into ureagenesis, and so not really helping, and perhaps even being a metabolic burden. And we don't know where it stops, and we don't really know how it works, but we will discuss this also in the course. Glucagon may be an important driver, and in fact, the proteins may be driving their own breakdown. Very exciting, very complex, and we are still looking for an easy to read indicator when an individual patient is ready to receive more nutritional and particularly protein support. Because in fact, this is a slide by Yves Barry from France, discussing the resistance of muscles towards anabolic interventions. And as you can see, this is not made for the ICU. This slide is just general population and different pathologies. But in fact, all the good guys on the left side, exercise, testosterone, vitamin D, antioxidants, are all rather rare in the ICU. And all the bad guys on the right side, the anti-anabolic factors, like cytokines, inflammation, immobilization, some kind of fatty acids that normally circulate less in our blood, are more there. And of course, this makes it all, I wouldn't say frustrating, but at least a bit difficult. And broadly, and also Stefan's group has been focused on this for quite a while, is the combination of being able to restart muscle exercise, having muscles doing better, being more, doing better integrity, and then feeding. That will be the way to go. But this is something we are still further investigating in many centers nowadays.
So there's a lot of ICU clinicians, I think, who will have the feeling that, oh, it's just nutrition. Don't worry, just give the nutrition to the patients. It doesn't matter. But I think that we do have evidence to suggest that actually there is a potential element of harm to providing incorrect nutrition support to our patients. And it is really important that as clinicians, we are aware of what harm may be attributed to nutrition support and how we might be able to prevent that, detect it, and monitor it going forward. So some examples would be particularly with our high rate of obesity that we have in the ICU, and I think this was really prevalent during COVID times. There is a high chance that we might end up overfeeding ICU obese patients because a lot of centers don't have indirect calorimetry. We're not able to measure the energy needs of the patients, and we have to use our predictive equations, which can certainly lead to overfeeding, which can then go on to lead to hyperglycemia, which we know can lead to worse outcomes in ICU patients. So being able to monitor those patients and prevent that from happening is certainly one element that we need to think about. The other side to that is, of course, underfeeding, which can lead to malnutrition. And back to my earlier point where I mentioned that feeding protocols, in my opinion, are only suitable for the first 48 to 72 hours of ICU admission. That's because I think if the patients are not monitored and they're just left on the same feeding rate throughout their whole ICU admission, that can potentially lead to the detrimental effects of malnutrition if that's not monitored. We can see a lot of malabsorption, particularly in patients who might have pancreatitis and may not be able to absorb an enteral feed without pancreatic enzymes, or potentially the use of parenteral nutrition. Patients who come into the intensive care unit can be at risk of refeeding syndrome, which does require a certain type of calorie restriction initially to be able to prevent that from happening. And then there is also feeding hyperphosphatemia that occurs following feeding. That should actually be the other way around. And I have put that separate to refeeding syndrome because I think there's a big difference between the true definition of refeeding syndrome and a patient who becomes hypophosphatemic that doesn't have other risk factors for refeeding. The next slide, please, Michael. So I wanted to touch on that in a little bit more detail because we do have a randomized controlled trial that did look at restricted caloric provision in patients who developed what was called in this study refeeding hypophosphatemia. That was patients who had a drop in their phosphate within 72 hours after the commencement of enteral or parenteral feeding. Again, in my view, this isn't necessarily the true definition of refeeding, but it is what was defined in the study. And what they did was randomize patients to receive either a caloric restriction or standard care after that phosphate had already dropped. So what they found was in the patients who were randomized to the caloric restricted group, they had lower insulin needs and, of course, lower blood glucose levels, which makes complete sense. Next slide, please, Michael. And I should say, actually, in these graphs, you can see here, the red line is the standard care group and the blue line is the caloric restricted group. In terms of the primary outcome, they found an increased survival time in the group who received a caloric restriction, but there was also a longer hospital length of stay and worse general health at 90 days in that caloric restricted group. So I think what we can see here is that if this isn't prevented and detected and monitored, it can actually lead to potential harm in our ICU patients. Next slide, please, Michael. And I think one of the more common risks that we do talk about is the risk associated with bowel ischemia when we enterally feed patients with severe shock who are on vasopressors. And most of the data that we have regarding this topic is observational, but there is one randomized controlled trial. Next slide, please, Michael, which is the Nutria 2 trial from Ranier et al. In France, where they randomized patients to receive either early enteral nutrition or early parenteral nutrition if patients had shock and were on high-dose vasopressors. And whilst they didn't find any difference in the primary outcome, what they did find was that there was a higher incidence of bowel ischemia and colonic pseudo-obstruction in patients who received enteral nutrition. So again, secondary outcomes, so really hypothesis generating, but really does go to show that actually there can be some harm associated with nutrition, and we need to be mindful of that in our nutrition assessments.
Thanks, Danny. And while indeed there are risk elements to take into account, particularly in the early phase when patients are more shocked and ill, another risk is that many clinicians and researchers feel as if nutrition stops having importance as soon as the patient is weaned from the ventilator, and certainly as soon as he leaves the ICU. In fact, some studies stop the intervention as soon as the patient is extubated, and almost all studies, unfortunately, also ours, do not go on after ICU discharge. While in fact, this post-ICU phase and the transition and the briefing from ICU to the regular ward, or maybe the step-down unit, if you have a step-down unit, is very important. This is a small but nice study by Dr. Ridley, who showed in a group of some 30 patients after a long ICU stay, with an even longer hospital stay, of course. And then in the more than half of the days after ICU discharge, patients were on exclusive oral nutrition. As we all know, in the ICU, almost none of them make it with only oral nutrition, and it doesn't change immediately after leaving the ICU. And if you see here this data, how much patients received when they are on exclusive oral nutrition, you can see that this is less than 50% of the calculated energy and protein target. So, and this is an area really, I would say, in the shadow, which is very often not included in the data that we see in our studies, and also not included in our clinical practice. And I think if we aim at making better protocols, that we should certainly take this into account and even include systematic approaches to monitor what patients received after leaving our ICU, or collaboration with the nutrition team, of course, making a continuous transition from the one to the other situation. Particularly as one of the few recent RCTs showing true benefit by a nutritional intervention, benefit as in heart outcome being improved, was in patients outside the ICU. They were not post-ICU patients, they were severely ill acute patients. Some of them spent some time during the study in the ICU, study by Philipp Scheutz from Switzerland. And a study where in such high-risk, severely ill patients, nutritional intake was improved mainly by giving oral supplements. In fact, the protocol included also artificial enteral nutrition and parenteral nutrition, but almost all patients received only oral supplements. But the intervention was continued in 25% of patients, even after hospital discharge. And these acutely ill non-ICU patients were much more likely to reach a higher proportion of energy and protein target when they had the intervention, as you can see in red as compared to blue, in a fairly large study. And interestingly, the number of patients being free of complications and surviving on the long term or middle long term after the intervention was higher in the intervention arm, even though afterwards they did detect in a post-hoc study that some of the intervention patients were more at risk of, again, some kind of a refeeding syndrome, which was associated with some additional harm. But this is, I think, a very optimistic signal showing us that we can really improve outcome also in our CTs with nutrition, and particularly maybe in the post-acute or the non-critical ill phase. So in conclusion, I would say, and of course, then he can complete where I would be incomplete, that nutrition support in the ICU is complex. It starts rather simple and avoiding mostly collateral damage. But as Danny says, after 48 or 72 or a bit more hours, it becomes more and more complex and less one fits for all. It is crucial because it's part of recovery and recovery starts soon in the ICU, I think. It's not without risk, so you can't make it too simple, certainly not in the long term. And it is time dependent. And we don't know today where this time shift occurs, where nutrition therapy can be enhanced and is more likely to produce benefit. And that's certainly one of the things we'll discuss in detail, when and in whom also, the so-called nutritional risk indicators. And above all, I think, and I hope we've convinced you, I'm sure Danny did, that it is a fascinating topic. And with this, I will conclude, unless Danny has something more to add. No, okay.
No, they are perfect. I agree with every single one of those points.
Thanks, that's great.
Yeah, thank you, Danielle and Michael. Our next part will be that we have some poll questions for you. And I will start with the first one. And while we're waiting for the poll, we already had one question I would like to ask from the audience. The question is there any potential in giving normal food or enteral feeding instead of the usual commercial products?
Can I start with the answer to that? Do you mind?
Yeah, sure.
Great. This is actually a question that we have been getting more and more and more. And I think particularly because we're also seeing a higher number of patients come into the ICU who are vegan. And we actually don't have any available vegan enteral feeds. So it is a request that is coming up more and more. And it is something that I think is performed more in pediatric patients than in adult patients. I guess the reason that it was stopped so many years ago doing these blenderized diets to put down enteral feeding tubes is because of the risk of infection. And I think that risk of infection definitely still exists today. So it is, I would think in the ICU is a lot more complicated to give a blenderized diet down a feeding tube than it would be in a patient who perhaps has a long-term feeding tube and lives in the community where it might be a lot safer to manage. And there's also obviously the risk of blockages of the tube. So having to have that tube replaced multiple times, which in itself is also a risk. And then lastly, how do we make that blenderized diet from a normal food complete in micronutrients? And how do we manage the calorie and protein content of that, which is actually really, really complex? So I don't think it's impossible, and certainly in more developing countries, that is the way that they provide enteral nutrition to ICU patients. But I don't think it's without risk, and I think it's very, very complicated to do. That would be my thoughts on that question. I'm not sure if the others have any other thoughts.
Yeah, if I may, first, I think many of the elements Danny touched upon are very correct. That's the whole process is less controlled when we give more room to homemade foods. But then first, it is possible if necessary. I was lucky to work in Haiti 20 years ago, and the only enteral feeding we had was provided by the proxies. So it was a very basic condition, of course, but in a this or nothing condition, it does work. But of course, you can compare how it would have been with more sophisticated foods. But then I think also in the patients doing better, going more into recovery, and many of our patients are extubated earlier, but still stay a long time in the ICU, particularly also the large trauma and wound patients. And just the fact of being allowed to ask one's parents or partner or children, can you bring my favorite food? Even if it's not meant to be the main component of our nutrition therapy, because indeed I fully agree, Danny, that it's never the same. You don't have the same control on what's in it and whatever, but on allowing some self-control for the patients, and sometimes also being somewhat closer to one's own cultural and maybe also religious background, may be very valuable. And it's really a trade-off between these process-related risks and having at some point some space for a patient-centered approach. Of course, it also depends on a hospital. If you're in a hospital where people have many different cultural backgrounds, and they can easily say, oh, please do me my favorite meal that we typically eat in this time of the year, then it's also easier to stay within the hospital meals, I think.
Okay, thank you, Michael. So our first poll was, do you have a nutrition protocol in the ICU? And it was quite a split. So 60% said yes, they have a protocol in the ICU, while 40% said they do not have a protocol yet. Any comments on that? So I think, Michael, you said in the beginning that you think a protocol is quite necessary, right?
Yeah, I do think so, because I think that if the 40% who don't have a protocol don't have it because they have dietitians or other nutrition experts available 7-on-7, 24-on-24, and so they're so well organized that the protocol wouldn't bring any added value, then I'm very happy for them, but I would be surprised that this is the case in 40%. And I think that even then, all of us, and particularly the nurses, like to have some structure, even if you'd say, yeah, you don't need it because we're going to tell you, but knowing what's going to happen, even if you would have a very expert input, I think is still very valuable. And also protocols reduce the risk of errors, reduce the risk of miscommunication. I think over the last 20 years, we really shifted from ICUs where many, particularly physicians, said, no, this is cookbook medicine, well, not only in nutrition, but also in how do we manage hemodynamics, towards knowing that, in fact, having a mainstay for certainly the early phase in 95% of your patients, and then gradually giving more diversification will, I think, reduce the amount of errors made and will reduce the stress for everybody in the team, even also for the person in logistics who has to fetch the adequate nutrition. It's easy to know what is most probably going to be the prescription.
I think I agree with that, actually. I think it's important to have the early standardization. I think that's the key. And then what happens later, you can manage the patients individually, but I definitely think early standardization is important.
So let's see what Michael referred to with the next poll question. Do you have a dietitian in your ICU? And I start this poll now, and I invite everyone in the audience to answer that. While we are waiting for this poll, we have a next question, which is, are there any studies that are just outcomes for nutrition with mobilization? I think that link is so tied together regarding to outcome. Well, I will take that myself if it's okay. So as far as I know, there is no nutrition study really linking that very well with mobilization. However, there are some obstacles. For example, how to define the dose of mobilization is not clearly defined, or there is no uniform definition how we would do that. We have now scorings, for example, for level, but the combination of level, duration, and frequency of mobilization is not really established yet. What we have recently, we have now studies which combine mobilization and nutrition. So really using a combined intervention, and there are some promising results. And also Michael said already, several centers are looking into that. So there is something going on there. And there's also a multi-center study at the moment going on in the US, the Nexus trial. So there will be some further information in the future. Okay, we have the same respondents number, so I will close that poll. And so, still coming in, so I wait a little bit. So, but it's approximately the same. We have now a split of 55% and 45%. 55% having no dietitian and 45% having a dietitian. So, Carole, as a nurse, do you need a dietitian in your unit?
Absolutely, and that's not just because Danny's on the panel. I think having a protocol means that if a patient is admitted at 3 a.m. when we don't have a dietitian present, I think it means that we can actually initiate some nutrition. But I think when we're getting past that first 48 hours or so, I think it's absolutely key to have real interaction with the dietitian who can actually look at what medications we're giving, and propofol is the classic example, and also what we're actually doing as part of a management plan with that patient. It means that nutrition stays as part of the focus of the entire repertoire of the things that we're dealing with the patient, because sadly, nutrition may, for the nurse at the bedside who may be managing renal replacement, who've been managing complex ventilation, who've been managing vasopressors, without an initial protocol and without that support from a dietitian guiding that as the patient goes through their journey, that there is a real potential that could be done not as well as it should be. So absolutely, we really value the contribution of the expertise that dietitians have. Otherwise, who's managing the nutrition in the units if it isn't a dietitian? Is that led by the physicians? Is that led by nursing staff with an interest in nutrition? I think having an expert communicating with the entire multidisciplinary team definitely makes a difference.
Danielle, do you want to add something?
I think that's a great answer. I think my view is that I think if there's not a dietitian, it's really, really important to have someone who does lead the nutrition service on the intensive care unit and is involved in making sure that nutrition is everyone's business, because if no one has an interest in nutrition, then it isn't ever at the forefront of anyone's minds. And I think that's the important part. And that's what a dietitian provides. But if not a dietitian, then there just at least needs to be someone who has an interest and leads on the nutrition aspects.
Thank you, Danielle. So I will start the next. Yeah, Michael.
Sorry. Yeah, I fully agree, and more over the years, you see it like in our unit, we have a tradition where the nurses are very much involved into the early nutrition phase, but have also well, very soon they wouldn't feel comfortable to be the person leading it. Some doctors are very interested, others are less interested. It's also very time dependent. Myself, I plan very often to do nutrition rounds, which then happen not quite often enough. So I'm more and more convinced that we would need much more involvement of dietitians. But one thing I wanted to add very shortly is I think the pitfall not to fall into is if someone takes care for nutrition for you as a nurse or as a physician, it shouldn't be out of your head. And my two focuses are nutrition and wound care. And we see in the two fields the same problem that particularly physicians have a tendency, if there is a dietitian or if there's a wound team, to totally zap this part of therapy, which of course is very dangerous because everything, as you all know, needs to be totally integrated. And so the dietitian needs to be informed and briefed on a very frequent basis on the planning, the things that happened, the therapies that are going to be started, and the physician should continuously know not only what is given as nutrition, but also why and where the idea is to go, because else you start living in split worlds. And that I think is maybe counterproductive, although maybe perhaps less dangerous than having no management at all, of course. But still, that's the integration, in my eyes, is very important.
Thank you, Michael. So the next polling question will be, do your patients receive specialist nutrition input when they are discharged from the ICU? And I will start the polling again, and we'll have a look at the next question from the audience while we are doing that. The question is, do you recommend any score to detect gastrointestinal dysfunction in ICU patients?
That's a difficult question for me. We don't use a score. Michael, do you use anything? We don't have anything.
No, we don't have. I don't think. And Annika Rand ambassador would kill me if I'm mistaken, but I don't think we have a validated score at this point. I think that particularly Annika is really struggling on progressing here with the intestinal SOFA score, endorsed by ESICM, by the way, in observational prospective research, where she tries also to distinguish truly intolerance from just a patient not receiving something, because some scores include the dose received, but a physician not prescribing nutrition is not GI intolerance, it's just, I wouldn't say laziness, but just someone not prescribing something. So the ISOFA is something that is worked on, but I think today the daily or even more than daily clinical examination of the patient and just asking, how do you feel? Are you thirsty? Are you hungry? Are you feeling like you're going to throw up? And abdominal examination. These things are, I think, still very important and also not so easy to convert into scores that can be ticked in the patient data management system. So I think the answer is no.
Thanks. So our result here is clear. So 80% do not receive special nutrition input, or 80% answer that their patients do not receive specialist nutrition input when they are discharged from the ICU. So only 20% have this possibility. So perhaps something we could work on during the course. I
think that's really important, and I think we should definitely pick that up during the course, because there are lots of barriers, as Michael already mentioned, to managing nutrition support in the post-ICU phase, and that's probably quite an important part in the patient's recovery, or definitely is an important part in that patient's recovery. So that will be an interesting one to pick up.
So our last polling question is, do you assess body composition or nutritional status in all of your ICU patients? And I will activate the poll. And in the meantime, again, I have another question from the audience. What's our expert opinion about proper timing to start enteral nutrition after gastrointestinal anastomosis surgery?
Shall I?
Yeah. Go ahead, yeah.
So the
yeah, I think it's an important question, first of all, and I think we are lucky that many surgeons made a major shift here thanks to the ERAS protocols, which in fact were not made for the ICU, but revealed after major abdominal surgery that going away from this keeping patients without feed for several days and shifting towards earlier feeding, early mobilization in the non-ICU ward really appeared to be beneficial for recovery. And thereby nowadays, the experience shows that in patients with lower anastomosis, after major surgery, you can start almost straight away with some enteral nutrition, mostly very digested nutrition. And in patients with a higher anastomosis, they also start already after 2 or 3 days. However, it's a dogma shift because before it was endless intestinal preparation for surgery and then a week of nothing per os. But extrapolating these results to the ICU should be done with caution because, of course, the patients coming to us have anastomosis often being made in a hostile abdomen, which is already infected, where in fact the question is, should we make anastomosis or should we rather have a transit diversion of the intestinal content? So if a brave surgeon decides to stick this all together and say, okay, I know from ERAS that we can start very early. Maybe there it is not a bad idea to contact the surgeon and ask him how it looked, how was the abdomen when you opened it? Was it still, was it clean or was it fecal contamination? Did you doubt a long time before making anastomosis? So I think it really depends on where are we in the intestinal tractus, but also how was the context? But I'm happy to hear you disagreeing, of course, also.
No, I was going to say exactly the same thing, actually. We do not have a standardized approach to that in our ICU. So certainly we have an ERAS protocol for the ward, but as you mentioned, an ICU patient is completely different. And we end up most of the time, exactly as you said, Michael, phoning the surgeon and having a conversation about what did the bowel look like and at what point will we be able to start feeding? Is it safe to do so? What are the risks? Because often, or not often, but in a lot of occasions, there's also a plan for that patient to potentially go back to theatre at some point in the next couple of days as well. So yeah, for us, it's not standardized at all. And the discussion is usually with the surgeon.
But in my understanding, is it not that a trophic feeding would not increase the risk, for an anastomotic leakage problem? It would either be better for the gastrointestinum to get the normal function back. Wasn't that also like the sense, at least in the ESCM guideline, as far as I understood it?
I think that would, in theory, probably be the case, but I'm not sure in practice that is actually what happens. And what I find when I have conversations with surgeons, and I have a patient who comes to the ICU who has had some sort of bowel surgery and a primary anastomosis, and I think to myself, well, we should be able to feed this patient enterally. I don't really understand what the issue is. And then I phone the surgeon and they tell me what that bowel looked like and how difficult the surgery was. And I can understand why they might be a little bit more reluctant to start enteral feed initially. So I think in theory, it makes sense. But I think when I have the conversations with the surgeons, it doesn't really marry up with what that recommendation suggests.
But it's also the the feeling of the surgeon is also not evidence-based.
Absolutely. Yeah, absolutely. It's not. And neither is my feeling about what we should do. It's not evidence-based at all. But I mean, I think you're right. I think the honest answer is we don't really know the answer because there is no study that has looked at that as far as I'm aware. So yeah, I think that probably explains why it's not standardized in an ICU setting.
So, yeah, Michael?
I also think that indeed I agree with Danny that the general idea, right, what you refer to, Stefan, is the intestinal mucosa being protected, the integrity being protected, which particularly has been shown in animal models, particularly in rats, who very easily start leaking bacteria when you fast them, even when they're not particularly ill. And there is some evidence that the flow towards the intestinal tissue improves when there is some feeding. But in the same time, also when you feed, there is a possibility of increasing the secretion of these somewhat aggressive liquids that help the digestion. So of course they can also digest a very vulnerable anastomosis. And another thing is okay, if it is really trophic feeding, the risk of mechanical distension is maybe not so high, but then if your trophic feeding goes towards somewhat more increased and maybe fibers and there is some bloating, then of course there can also be a mechanical stress. But the whole thing is, as Daniel also said, that studies really showing or refuting the protective effect of prolonged trophic feeding as compared to no feeding have not been done. I think the calories trial and the trial by Jean Renier were too short in the days of giving enteral or parenteral nutrition to be able to show eventually that, let's say, 10 days or 14 days of enteral nutrition is protective for the gut. So that, yeah, in brief, we don't know. And the ESPEN guidelines finally, or the ESCM guidelines also advise to give some feeding because the aggregated data still shows some reduction in overall rate of infections, but that's also rather weak evidence, unfortunately.
Thanks. So the last poll showed us that 2/3 of our audience who answered the question do not assess body composition or nutritional status in all the ICU patients. And I think I assume that we will convince at least the attendees of the program of thinking about this part. So we have several other questions. Shall I continue with them, Michael?
Yeah.
Okay.
If Carole and Danny agree, yeah.
Then let me just check that I have. Oh, yeah. So the next question is, how do you manage diarrhea in patients who have been started on enteral nutrition? How do you modify your nutrition provision in such patients?
I can start with that if you like. So I often find from our nutrition assessments that the diarrhea, at least initially, is not at all caused by the enteral feed. It is caused by an overprescription of laxatives, which we have on our standard order set. So the first thing to say is first check if the patient is receiving 3 different laxatives before blaming the feed. The second thing to say is I find a lot of antibiotic-associated diarrhea as well. That is a real issue for us. And quite difficult to manage because obviously you can't stop the patient from having antibiotics. That's crucial for their care. So once we have excluded other causes for diarrhea, so malabsorption, for example, laxative use, antibiotic use, we might then try an enteral feed that doesn't have fiber. So our standard enteral feed does have fiber in it, but we might change to an enteral feed that doesn't have fiber and see if that works. Usually give it 48 hours. And if there is still diarrhea present, we would move over to a semi-elemental feed. In most instances, we find it's actually not the enteral feed at all that is the cause. But there is definitely, liquid is going in, liquid is definitely going to come out. But I think there is a lot of other reasons and a lot of other causes for diarrhea rather than it being an enteral feed from the outset. That is my experience.
Thanks. So I'm looking at the time, and so this reminds me that we have, before we also go for the additional questions and the questions I have left out yet, we have also the part where we want to talk a little bit, at least, about nutrition from the multi-professional perspective we have also here at the moment. And I think we have the time to take on this part, and then the questions we have not answered yet, we will have time afterwards. So who is going to start in this one? I think...
Michael, I think.
Michael, yeah.
Okay, thanks. I'll start, but I'll be brief because I think we want to have maximum interaction, and I've been talking already too much. So, we manage our nutrition really together in our ICU, but I feel that we under-manage it, that it's often a bit too much, how would I say, in the background in the early days of therapy. We have as we don't have sufficient integration of dietitians, certainly in the early phase of our patients. They are very active in the long stay patients, but on a weekly basis, rather, I would say. We have the nurses executing our simple feeding protocol, which is focused at doing things that we really think are helpful and avoiding as much as possible additional interventions. And I think maybe during the short course I can share it. So it's a one-page thing, and the nurses increase the feeding. According to standards, they have the authority to treat high residuals and diarrhea. And depending on the subunit, the burn and trauma unit, the nurses are very active in monitoring whether the patient reaches the target. But this is very different, a bit depending on the subspecialties. But then, of course, thereafter it becomes much more complex, and whether this is 72 hours or a bit more or a bit less, but then the point where the patient can no longer be administered feeding just based on the age, the gender, and the ideal body weight is somewhere between 5 and 7 days, I guess, after admission, because we take some time to increase. So we can't overfeed them because we don't give parenteral nutrition the first week, and we are very gradual in increasing the enteral nutrition. So the only thing that we risk is to be too slow. But then at some point, of course, there is much more need for recalculation of the targets, eventually also indirect calorimetry, which we do in long stay patients, but not so much. And then figuring out particular problems. And also solving things like, just mentioned before, patients with ongoing diarrhea, which is a severe burden for the patient, if he's awake or if she's awake, also for the patient's dignity, but also for wounds due to humidity, and an enormous additional workload for our nurses, particularly for those doing the burn and trauma patients with large wound dressings that can't stay, at least not for long, can't stay while it's stained and smelling due to diarrhea. But I was going to be short, so I stop here.
Thanks, Michael. So, Carole,
sorry.
Yeah, go on.
So a few observations for me from around nurses and their contribution to nutrition in the ICU, but also a few challenges, because I think the nurse is ideally placed because there's a nurse at the bedside 24 hours a day. And I think there are some missed opportunities. to playing a crucial role in identifying patients at risk of where nutrition isn't optimal for the individual patient. We're also in an ideal position to be able to be the early warning system for the patient's residual volumes are increasingly high, and the early escalation of that to get prokinetics prescribed and administered. Also, the safety aspects around, positioning of a nasogastric tube, how many times of hours and hours of effective enteral nutrition been lost because the NG tube wasn't quite in the right position, and then there was a delay getting the X-ray and the pH wasn't right. And there's something about increasing the focus of nutrition for the nurse at the bedside alongside all of the other therapies that we need to be managing. But actually nutrition is a core part of that. And I think dovetailed with that is the nutrition that ICU nurse, the nutritional education that ICU nurses receive maybe isn't taken up as much as it should be. I think probably we need to be drawing on our the expertise of our dietitians to actually reinforce the education that nurses are getting. And the evidence out there very much is that education around nutrition, and hopefully this series will encourage nurses to take more notice and improve the education and knowledge that we have around nutrition in the interest of providing better care for our patients. Startling for me is that nearly 50% of ICU patients could be classed as being malnourished, and actually some of the simple things that we do as part of our day-to-day management in terms of head-up positioning, in terms of avoidance of delays in starting nutrition and avoiding making sure that there are long breaks in nutrition. Good education can help with that. And throughout the series, I think we can challenge some of the ways that we actually view nutrition as part of the holistic care that we give our patients across our units. From an organisational point of view, do we really make the most of our experts in terms of the dietetic team, or do they come do a nutritional ward round and then disappear? Do we actually actively engage in what some of the issues that we might have with the patient at the bedside, which we might not perceive may have some solutions in nutrition? But I really do think that with effective education and dialogue, we can actually build on what we already do, but actually increase the focus, because nutrition is part of every aspect of what we're trying to deliver with the patient. So a few challenges from me. I think we need to challenge our knowledge. I think we need to challenge how we work as organisational teams to value the experts, and also be able to use the early warning system of having a nurse at the bedside, that actually there are some issues that could be addressed in a more timely way for our patients.
Thank you very much, Claire. Michael, you wanted to say something?
Yeah, if I can, and then I give the word to Danny, but I was just talking or listening to the organizational part of the job. I think I'm convinced that there not only this organization and the protocol and whatever is important, but particularly also in nutrition, and perhaps everything we do shared, is that the trust and empowerment. If you decide, for example, as we did years ago, to say, given our context, a large ICU, a huge turnover, that nurses are allowed to give on a kind of a deferred prescription directly themselves antidiarrheic or prokinetic drugs, then it's an endless work, and I have to blame myself here because I often see that I don't do it enough, endless work to inform all physicians coming in your ICU that this is what has been agreed, and so that they should not all of a sudden say who started this here and how did someone prescribe these drugs to my patient with me not knowing it, because we have a huge turnover, you see, and I think, and it's the same with protocols for early mobilization decided by nurses and physiotherapists. If in this very stressed environment, particularly colleagues who themselves are a bit stressed by things happening, have a tendency from time to time to say, who decided to take this patient out of the bed, or who decided to increase the enteral nutrition while I'm the doctor, while I'm the whatever. Then everything, even the best organization can, how to say, crumble down very, very easily. That's something I wanted to add because I was going to forget it, but now I give the word to Danny.
Danielle, can you perhaps also allude a little bit or explain to our audience, because as we have discussed before, dietitians are not available everywhere. How often are at the ICU, so that people who do not have access to you and others, how we can see how you work together with the ICU team?
Yeah, absolutely. And I think we are very unique in the United Kingdom in that critical care is a specialty for dietetics. So, for example, my sole clinical role is within critical care, and I'm fortunate enough to have a team of 6 dietitians just working only in the intensive care unit. So we are able to review every single ICU patient, which we do within 48 to 72 hours of their admission to intensive care. But before I go on and tell you what we do day to day, I do want to agree with what Carole and Michael have said, in that nutrition really is what I like to say, a team sport. And even though we have a lot of dietitians on our ICU and we are able to review every single patient, we see the patient and we do an assessment and we write a plan and we walk away from that patient. It's the nurse who's there by the bedside, 24 hours a day with that patient, who is implementing that plan. So it is incredibly important that we do empower the nurses and provide them with the education that they need and the training to be able to deliver the plan that we kind of leave at the bedside. Otherwise, there's no point. So from our perspective, as I mentioned earlier, we have a nurse-led feeding protocol. So the nurses will start the enteral feed without having to have a review by a dietitian. And then we will come along in a few days' time and review that. My team attend the medical handover every morning, Monday to Friday, and input into the care of the patients within that medical handover. And on Wednesday morning specifically, we have what's called a therapies ward round. So we focus specifically on long-term patients, and we have a longer discussion from physiotherapy and speech therapy and dietetics and pharmacy and occupational therapy on any issues that are preventing that patient from progressing with their rehabilitation. And that's a really, really important part of our week, and it's very multidisciplinary. We run multiple education sessions for nurses. So on their ICU induction, they get a session for nutrition, and then we run multiple sessions through the year. We do teaching for the doctors and also for medical students. And just recently, we've started an education program on nutrition for nursing assistants. So we try and include the whole MDT within that. And then we often get requests from physiotherapy and from pharmacy for nutrition teaching as well, which we are obviously very happy to do. My team lead on the development of the protocols and guidelines for nutrition in the ICU, and we always make that multidisciplinary. So we always have input from pharmacy, from a nurse, and from an intensivist as well. So it's not solely kind of put together by the dietitians. We make sure that everyone is involved in putting those guidelines together. And then, of course, we run lots of audits and service evaluations and research. So we know exactly what we're providing to our patients in terms of a nutrition provision of nutrition support services, which is really good. So it sounds amazing. It's not perfect. And in my view, I know I said we have 6 dietitians. That is nowhere near enough for the size of our intensive care unit in the way that we would like to provide our service. But it does mean that we are able to oversee the nutrition support whilst, of course, empowering the nurses and empowering the doctors to make decisions for the patient as well. But they are very good at phoning us for any specific questions, and we are really grateful for that because, if there's any issues with feeding tubes, as Carole's mentioned, or questions around the route of feeding or how much feeding to provide, or a patient's not eating and drinking enough, what can I do? We are there to be able to support them, which is great.
Thank you very much. So with that, I want to continue with our question and answers. We have several questions still open. The first one, I think, is also where we have started a little bit, and also where we had the last poll questions about nutritional status assessment. So what is your opinion is the best tool for adults and for children upon admission to an ICU?
I'm happy to start with that one if you like, but I will say I've never worked with pediatric intensive care patients, so I'm not very comfortable answering the pediatric side of things, but Michael might know a little bit more about that side than I will. But in terms of nutrition assessment on admission to ICU, we do not have a very good tool at all. There are, several that have been proposed. So the nutrition risk score, for example, the subjective global assessment, which is a physical assessment, which probably isn't a great assessment tool within the first few days of ICU admissions because the patients have a lot of fluid on board, which means that you can't really get a good, you can't really assess them, I think, very accurately. So at this point in time, my opinion, which is potentially a little controversial, and I hope that it does maybe lead to some discussion, is using your eyes. So, someone performing a physical assessment on that patient. So, having a look at, their muscle mass in terms of, the elements that are in the SGA. So do they have evidence of muscle loss? Do they have evidence of fat loss? What's been going on at home prior to that patient coming into the intensive care unit? Can you speak to the family and ask whether or not, they were eating and drinking normally before they came in? Did they have a long hospital admission before they came to the ICU? Because we know patients who are in hospital for a long period of time are at high risk of malnutrition. So that's going to have an impact as well. What's going on with them from a clinical perspective, because that is going to help you to gain a better understanding of the nutritional status of that patient. So my view is at this point in time, we do not have a very good tool to use to assess patients. And my view is simply to do a physical assessment yourself and consider all of the factors that may lead to a poor nutritional status. It is not going to give you a score, but it is going to give you a very good overview of what's happening with the patient, and then perhaps where you should go with your nutrition prescription from there. But I'm interested to hear what Carole and Michael think about that, because I do realize that is quite a controversial view.
I actually very much agree with you, Danny, because from a nursing point of view, we use a MUST calculator, so a malnutrition sort of scoring tool, and it becomes part of a routine of a tick box that needs to be filled in on admission, along with the patient's property and who the next of kin is. And it doesn't have any context with how the patient is. And I think that's where, yes, there is some sort of assessment done and that ticks some organisational boxes, but that doesn't really translate into some of the things that you really need to know about the patient. So I'm a big fan of looking at the patient, talking to the family, finding out what's been going on, because actually that gives you a very real individualised assessment rather than a tick box that for many people, many nurses, when a patient is admitted, it is something that is divorced from how you plan your care going forwards. And I think there's quite a lot of work to do in that to actually make all the information that we gather by whatever means actually help to formulate a care plan, a management plan for that patient. So I agree with you. Look and talk to the patient and the family.
Yeah, and I fully agree also with both of you that these scores that we have been promoted a lot because people like to make some kind of differential approach, the first step towards individualization with an NRS score, with a Nutrix score. But in fact, we are not able to identify who is going to benefit from another nutrition strategy based on a Nutrix score and NRS score. And I was very happy this morning. I just read with some delay the updates on the ASPEN, the American ASPEN guidelines for nutrition in the ICU, which provoked a lot of commotion because some other authors were disappointed that the Nutri score was no longer in the main recommendations. But in fact, it is worse to think that you know who you can help with a specific intervention than to know that you don't know. And this is really the risk that we have with the adult nutritional risk scores. And among others, Yassine Arabi has shown this retrospectively. And we just, I will show this in the 2-day course. We also applied Nutri score in our large RCT, and it really didn't identify patients a posteriori, but patients who would benefit from more feeding. And in the children, it was even more pronounced. We did this nutrition study, parental nutrition early or late to supplement enteral nutrition in a large RCT of children in Canada and Holland and Belgium. And they have the, I think, Strong Kids score, if I'm not mistaken, which identifies patients at increased nutritional risk. And in this study, with this specific intervention, of course, these patients, these children at increased nutritional risk were more likely to be harmed by enhanced nutritional intervention. So it was really the other way around. Then still, I also fully agree, so we agree a lot. In fact, we'll need some discussion for the 2-day course, that even though the nutritional status at baseline today isn't really helpful in telling us who will benefit from more or less, it's no reason not to try to assess it clinically, I think, rather than with a tick box score. That, for example, a pneumologist treating someone with some kind of a lung disease is also going to measure or try to quantify the status at the start of the therapy, even though he knows he is not going to adapt the therapy towards the situation, but just to be able to follow our patients. So I think we still have to do this, and we still have to try and find and validate some way, a way of proceeding. But today, I think clinical judgment, very good, as you said, anamnesis, understanding what happened, understanding how long a patient has been on the conventional ward, waiting for abdominal surgery that then finally also was complicated, particularly for vitamin status, phosphate status, these kind of issues that can depend a lot on the story. But yeah, a score today is false, reassuring information. Gives us the idea we are navigating, but in fact, we are not navigating better than without the score.
Absolutely. Can I just give one very specific example on that? Because I think it is really important. Sorry, and then we'll move on. We are an ECMO centre, and we see a lot of ECMO patients in our ICU, more than 200 a year. And if I were to use a score such as the Nutri score, the ECMO patients come out as being some of the lowest nutrition risk because they're very young. And their Apache and SOFA scores come out as being very low because we've physiologically manipulated what's happening with these patients. So they don't score highly with an Apache score or a SOFA score, and they're young, and they have generally, within normal range or only slightly higher body mass index because the very obese patients are not eligible for ECMO in the first place. So they come out as being very low on the Nutri score. And if we use that as a marker of that patient's nutrition risk, then those patients may miss out on important nutrition because they've often been in hospital for a long period of time or in ICU for a period of time before they start ECMO, and they have a very protracted ICU stay ahead of them. So they're definitely at nutrition risk, but a score would never show that with those particular variables included. And that's why I think clinical judgment, as you said, Michael, is so much more important than a score at this point in time.
Okay, so it seems that was a question really for the whole panel. I have a short one now. How early should we start enteral nutrition in a patient with septic shock or with vasopressors? How do you do that in clinical practice? Who wants to start? Carole?
You go, Carole.
I think our protocol would be that we would start, but there would be a bit of an expectation that they may not absorb. So they would be on very small volumes for a period, and then assessed with aspirations and so on. So part of our protocol is even in septic shock, that nutrition would be started early, but accepting that it may not be successful in that setting.
Interesting. Danny?
We don't advise in our protocol anything different for patients with shock. So they still will be enterally fed early as per our usual feeding protocol, which suggests within 48 hours of admission or 48 hours of intubation. So they would be fed within that period. We always, in fact, I think 99.9% of the time feed within 24 hours, but we may not progress as quickly. It would just depend on the direction that patient is going in terms of their dose of vasopressors, whether that's increasing, whether it's stable, whether it's decreasing, but we would most certainly start early enteral nutrition. We don't have a protocol or a clause that says not to do that. It's generally based on an individual assessment of the patient.
Michael, do you do the same?
Yeah, well, we have no protocol saying that it should be delayed. I think that combined the nurse and physician taking care of the patient will decide when they feel comfortable. And I think, for example, that they will like the lactate to go down before they start, so that they can notice when it increases, because if it's still increasing and then you start enteral feeding and it increases more, the next shift arriving will say, okay, it's the enteral nutrition that provoked it. Well, probably it's not the case. So it's easy to have a bit of a stabilizing situation so that you can see what happens. And then I think, well, we are traditionally an ICU where a lot of patients were major cardiac surgery patients. And so the nurses and the elder physicians did see from time to time this kind of intestinal complications, so are slightly reluctant. And with the Renier data, what Danny showed in the first part of the talk, showing that indeed, if you are aggressive enough in a patient who just came out of an early shock phase with still high dose of vasopressors, if you increase really fast, apparently, although it's a secondary outcome, apparently you can provoke intestinal ischemia or non-occlusive bowel necrosis. So yeah, giving some enteral nutrition, why not? Delaying it, there's I think no reason, but would be careful on not increasing it too fast. But in my ICU, again, the tendency is already to be a bit maybe from time to time too slow. So I won't need to go around telling them that they have to be even slower, because then we remain at 200 kcal for a week, I think.
Thanks. So the next one is, I will just, because of time reasons, make a survey, just give a head note. Do you alter your feeding regime for prone patients?
No.
Okay, I thought that, so I thought we can handle that quickly. And then an interesting question also, do you use prebiotics?
No, we don't.
No, me neither. Okay, so this is also, I think we can go into more detail. There is some research going on, of course, and I think this is something we will discuss during the course. But yeah, I think this is. I think I will also answer or start to answer the question, who will benefit from vitamin D supplementation in the ICU? For that, I will start. And so there is one study which was investigating this, a randomized controlled trial, which showed no benefit in the primary outcome. There was a benefit in a secondary outcome in severe hypervitamin doses of vitamin D. And therefore, at the moment, another study is going on in this set of patients. It's an international randomized controlled trials. But until that, I think there is no recommendation we can give for vitamin D in the ICU. Anyone wants to add there something? Okay. So
very short, I think there's a single vitamin to be provided in high doses early in the ICU.
Yeah, correct. Okay, we will not be able to finish all these questions, but I think this shows very nicely, and I'm very happy about it, that there are a lot of questions and that people are really interesting to get to know things. And this is exactly what this course is about. And at the last 5 minutes we have now, I think it is important to discuss a little bit what's next, what's going on. And Michael will start to explain a little bit more how we are going to continue with the course. Yeah, Michael.
Thank you. I will start, and please, Stefan, correct me and complete where I'm wrong, because you know the process even better than I do. Are the slides visible?
Yes. Okay,
thanks. So what are the next steps? Well, the first thing is if you didn't apply already, well, apply. And you can apply to this nutrition pathway course via the website of our society. And I guess you all know the website if you are listening now. So there's a link. There is a link, but there's not so much time left. I think only a few days to send your application. And the application will be judged in the weeks thereafter, because I think there are already more candidates than places for this year. The course will be hopefully, I think, organized in the upcoming years again and again. But so your application will be judged, taking into consideration the different elements. And maybe here, Stefan, if you want, you can give some more detail, because you know the process.
Yeah, so the process is the same process as we had for the next fellowships the last year, which we also developed over time. So your application will have several parts, and each part will have scoring of points, which will summed up together. One part is the motivation letter, one part is the recommendation letter, then your teaching experience, your clinical experience, and your research experience. This all together, it's a simple scoring, will be part of the selection process for this first thing. And yeah, I think that's a quick summary.
Thanks very much, Stefan. And then for those of you who are selected to participate this year, there is time for self-study. Well, time, it's important, of course, also to have this self-study to be able to discuss and interact, because if you have to discover everything during the course, then the course will be too short, and particularly it will be very difficult to timely generate your questions on things that are maybe not clear. And I think that first of all, we should refer to the existing online material at the website of the society, and perhaps additionally, for those who are motivated, reading the guidelines that we generated with our ESICM Metabolism and Endocrinology and Nutrition, the main section on enteral nutrition, on phosphate, our study on micronutrients management in different ICUs are, I think, very interesting background to read if you have time before joining the course. And maybe also the paper I just referred to, this recent update of the American guidelines, just to see different ways the different people try to aggregate the information. And then there will be our lively 2-day interactive online course with all of us here present today, and many others, all motivated experts, multidisciplinary experts also, and I think all very good teachers. So it should be fun, and I hope we will particularly have a lot of interaction with all participants. And then there will be a pre and a post course kind of evaluation, a multiple choice evaluation, which will help us select who will be the 20 participants that can join a group of fellows, clinical fellows, nurses, allied health personnel, and doctors. If possible, we're going to combine them together to go and visit several centers. Well, of course, they will be distributed over several centers for a 1-week fellowship, which will be a combination of joining the ward rounds, asking different colleagues how they work, but also looking how research is organized, and also some kind of formal additional educational teaching moments, and of course a lot of interaction, and a pre and a post fellowship planning and debriefing is also foreseen. And then separated from this fellowships, just the fellowships will be in June, September. I think it will be rather September than June. And then we have this debriefing. And then I was going faster than my slides. I'm trying to go to the next slide. Yeah. And then this is about the research part in the training course, which is separated from the fellowships. We will try to inspire you into creating research projects or quality improvement projects. This will be discussed and guided during the two-day tutorial. In order to avoid many people writing many pages for only a few people being awarded, it will be a two-step process. So those that are motivated to write a protocol will first be asked to write an abstract. So briefly, but very attractively and inspiringly explaining us what they plan to do. And there will be kind of a pre-selection, and then a few of these participants will be invited to give a detailed protocol, really explaining what they want to do, how they're going to do it, including the statistics, the organization, the communication, whatever. And out of these will be selected the awardee who will receive during the Congress in Paris, first of all, the fame, of course, of being awarded a research award, which is very important because it's often the first step towards obtaining more research awards. The first one is the most difficult one, and then also the money, 5,000 euro. So now I talked a lot and maybe not so structured, so I'll be very happy if my co-faculty will correct me and complete me where I've been incomplete.
No, I think this was a very good summary.
Thank you. Okay, so then are there still urgent questions about this process in the WhatsApp, Stefan? Did anything?
No, about the process, there came nothing in yet.
And I think we can promise that we will discuss all the questions raised now. They are really informative for further informing our course. It's really good. I've only had a few moments the time to look at all these questions coming up, but we're very happy with this because it can only help us making it a more interesting course. Okay.
With that,
Carole, do you want to add anything?
No, other than we look forward to seeing you.
Okay, Danny.
Same from me. We really look forward to seeing you in June, and thanks for being with us this afternoon.
And same for me. So I leave Stefan the last word to conclude this webinar.
So I would like to thank the task force and especially the audience to be so engaging with the questions. And I really hope to see this engagement also in the upcoming course. Thank you very much for the attendance. Have a nice day. See you soon. Goodbye.